Hello and welcome to the presentation on reducing surgical site infections with methicillin-resistant Staph aureus and total knee replacement. My name is Teddy Theodorakis. I'm a Doctorate of Nursing practice candidate at Wagner College School of Nursing. At this time, I do not have any conflicts of interest, and all images and property of the photos portrayed in this presentation are property of their respective owners. Let's begin with a general introduction on orthopedic surgeries. There were over 22.3 million orthopedic surgeries in 2017, and that number is expected to grow to 28.3 million cases performed worldwide by the end of 2022. There are various types of orthopedic surgeries, such as joint replacements, such as a total knee, hip, or shoulder replacement, surgeries involving the spine, such as spinal fusions, surgeries involving trauma, such as intermedullary nail placement, or an open reduction internal fixation to stabilize the bone or fracture, and more. In this presentation, we will focus on the total knee replacement, one of the most common orthopedic surgeries. There were over 1 million total knee replacements in 2017, and that number is expected to grow to 2 million surgeries by the year 2030. One of the major complications of surgery is the prevalence of infection. Surgical site infections account for 14 to 16% of all nosocomial infections. When undergoing orthopedic surgery, 2 to 4% of all orthopedic cases will become infected, with higher rates of infection in lower socioeconomic countries. Surgical site infections place a large amount of stress on the patient, the provider, the surgeon, and the practicing healthcare facility. What happens to the patient that becomes infected? The patient often follows up at the hospital or the surgeon's office after their surgery. If the patient presents with signs and symptoms of infection, the patient will be readmitted to the hospital, where they'll undergo immediate surgery known as an incision and drainage, or IND, or a washout of the infected area. A tissue sample or swab will be taken at the infected site and sent to the microbiology lab for testing for a specific organism. The infected joint or hardware will be removed, and a temporary spacer will be placed in place of this joint. A patient with a serious total joint infection will often require a peripherally inserted centralized catheter, known as a PICC line, and will need to endure several weeks of antibiotic therapy. After the antibiotic therapy is completed and the patient is no longer showing signs and symptoms of infection, the patient will return for a single or multi-stage revision of the joint. Surgical site infection has severe financial effects on the healthcare facility as well. In the European Union, methicillin-resistant Staph aureus infections cost an average of 350 million euros per year. That's an average of 5,700 to 10,700 euros per patient per admission. In the United States, a one-stage revision was estimated to cost 24 to 38,000 US dollars per patient, while a multi or two-stage revision cost anywhere from 66 to 81,000 US dollars per patient. There are various risk factors for infection, which include poor glycemic control or poor glucose control, being obese or morbidly obese, malnourishment, smoking, vitamin D levels, often low vitamin D levels, not properly screening for Staph aureus, management of anti-rheumatic medications, poor perioperative antibiotic prophylaxis, poor pre-surgical skin preparation, a non-sterile operating room, not using the proper anticoagulation, and more. One of the main bacteria or pathogens that cause surgical site infection is methicillin-resistant Staph aureus. It's expected that 30% of the world population is an asymptomatic carrier of Staph aureus or MRSA. This means the patient or person is colonized with methicillin-resistant Staph aureus or Staph aureus and does not even know. MRSA is commonly found in the patient's nares or nose, throat, armpits, and groin. Patients with certain risk factors, such as being elderly, chronically ill, being an organ transplant recipient, cancer patient, immunocompromised, or more, are at higher risk of becoming infected with MRSA. MRSA can develop into a very serious and life-threatening infection, which can go beyond the total joint infection to become a pneumonia, a bone infection such as an osteomyelitis, become sepsis, or can even cause the patient death. What are the signs and symptoms of infection? So first, a surgical site infection is identified as an infection within 30 to 90 days after surgery. The infection can be superficial and involve the skin, or be much deeper, involve the soft tissue or muscle. The patient will often present with pain, purulent discharge such as pus, a fever, swelling, or erythema and redness to the infected site. If you refer to the photo, this is a classic presentation of an infected total knee. The knee appears swollen, red or erythematous, and is likely painful if palpated by the provider. If the incision site is not actively draining pus, the provider can express or press down around the incision site, and pus or discharge may be produced. How do we screen for MRSA? Screening is often done with nasal swabbing, or in the case of an infection, the surgical site is swabbed, or during the operating room revision, a tissue sample is taken there. Swabbing takes 16 to 48 hours to reveal results. The swab is placed upon a petri dish and grown in a microbiology lab. In the preoperative setting, if a patient tests positive before surgery for MRSA, the surgery will be changed to a later date, and the patient will receive a decolonization therapy so that their chance of becoming infected is decreased. How do we treat MRSA? When treating an MRSA infection, the provider must take into consideration the patient's situation, the presentation of symptoms, and the entire clinical picture. If this is prophylactic treatment of MRSA, mupirocin is applied intranasally twice a day for 5 days. If this is a joint replacement, the following revision on IND will occur as previously described, and then the patient will have a peripherally inserted central catheter placed, and the appropriate antibiotic therapy will be considered. The most common form of therapy is vancomycin IV that's weight-based every 8 to 12 hours, as well as rifampin by mouth for 4 to 6 weeks. If the patient cannot tolerate vancomycin IV, a different antibiotic will be taken into consideration, such as daptomycin, cefepime, and more. The patient will follow up weekly with their infectious disease doctor to check their lab levels, which can include inflammatory markers, CBCs, BMPs, and more. Preventing MRSA infection is imperative to reducing healthcare-related costs and improving patient quality of care. A common expression, an ounce of prevention is worth a pound of cure, applies in this situation. We've all heard before that washing your hands is important, but it's integral to preventing infection and should be done before and after every patient encounter. Providers and surgeons should make sure all operating room equipment remains sterile and that their operating room is at the appropriate temperature. When conducting surgery, the surgeon should make sure that there's limited admissions in and out of the operating room. Only people directly involved in the surgery should be there. After surgery, the sterile dressing should stay intact, and if the dressing becomes saturated, be changed immediately. The healthcare facility or surgeon should implement a preoperative screening protocol for MRSA for all preoperative patients. If the patient is high risk for MRSA, as described before, the facility or surgeon should consider implementing empiric antibiotic treatment for those types of patients. In the preoperative setting, patients should be given a chlorhexidine wipe 1 week before surgery, and they should wash daily with these wipes to reduce the incidence of MRSA. And above all else, a facility should consider implementing a preoperative treatment program such as decolonizing every patient with povidone iodine and/or applying mupirocin nasal cream to these patients. While there's no definitive treatment plan for MRSA infections, some facilities may use povidone iodine decolonization and/or mupirocin treatment and screening. At this time, there is research being conducted on which of these therapies is the most cost-effective and practical for implementation for decreasing MRSA infections before surgery. Regardless of the approach, a facility should have an MRSA decolonization policy in place. The facility, providers, and surgeons should stay up to date with the latest recommendations for prevention and antibiotic therapy for treating MRSA-related infections. If a provider, surgeon, or healthcare practitioner would like to stay up to date with information regarding MRSA infections, they should be referred to uptodate.com, which can provide information on Methicillin-Resistant Staph Aureus, its presentation, signs and symptoms, and the appropriate antibiotic regimen to take. If the patient would like more information on this infection, they can be referred to the cdc.gov, where a patient-friendly handout is available to answer all their questions. Thank you for listening to this presentation. Here are some of the references that can provide additional information on MRSA, the type of infection, its prevalence, and how to treat it.